So now we're going to talk about the cardiac arrest section. This is the one section that's going to be considerably different for us. We already talked that when we walk into a room, we got to make several decisions. So what is the first decision we're going to make?
If there's 7,
Yeah, whether we're going to work the code or not. So we're going to think of it a little different now. So in the past, we always talked about you need to have your 4 presumptive signs and 1 conclusive sign. Now we're going to think of it a little different. Once you have one of your conclusives, we're good. So that's not to say you can't include all your presumptives in the report still, but once we identify one of our conclusives, we're good. We can justify not working that patient. If the patient doesn't meet the conclusive criteria, that's when we would jump over to the other side. So when you're reading this, think about a patient with an unknown downtime, but we reasonably believe it's been more than 30 minutes with no CPR administered. The patient is asystole and has fixed dilated pupils. Those are the keys. We added apnea, but that's probably assumed, yeah. So the asystole, fixed dilated pupils is the key, and a downtime we reasonably believe is more than 30 minutes with no CPR. What is the survival chance for that patient? 0, exactly. So we realize that, we understand that, so now we're putting it in writing that we do not have to work that patient. If there is any doubt in your mind, you work that patient and you transport that patient. But this gives us the ability to call the patient without having one of those conclusive signs, because we know now there is no chance of survivability for the patient if they indeed have those parameters.
So that covers the gray area then?
Yes. That's really the intent of a lot of these protocols, was try to eliminate these gray areas and try to describe what we really do with good validation.
you have the no hypothermia, so they don't have to be cold.
Good point. So if there's hypothermia, we would still work the patient until there was no hypothermia. So down here, that's not the typical patient, but if you did find someone maybe in a freezer at one of the supermarkets, you would not use this, you would work the patient. Good, that's a good question. Yes, sir?
Known downtime, does that mean they haven't been seen in the last 30 minutes?
Could be. So that's a hard question to answer. But if you reasonably believe the person's been down with no CPR, and that's so, what does that mean?
If they're cold.
Yeah, so not the person that tells you, I promise you I was just talking with 10 minutes. But it'd be more likely, yeah, I don't remember when I saw him. Yeah, it's been hours.
I came in the room and found him like
Right,
this.
exactly. So if we decide to work the patient, so they didn't meet this criteria or we had any doubt in our mind, that's when we talked about, I'm deciding, is this a primary arrest or a secondary arrest? So we'll first talk about the adult, and we're assuming it's a primary arrest, so we'll go down the algorithm like that. Now just be aware, when you read, there's a lot of information in here. So there's no way you're going to be able to absorb all this right now. So I'm going to hit the high points. There are subtleties through here I won't talk about unless someone asks a specific question. So the intent right now is to get more of a general overview, and then we'll do more hands-on muscle memory training in the near future. So I have my adult algorithm. So does my patient have a pulse? If they do, our classic overdose scenario. We know how to do that very well. If they don't, I begin CPR. So it talks about a pulse compression rate of 220. So when you remember with ACLS, the rate is 100 to 120. So we easily could have put 200 to 240 compressions. They believe that the optimal number of compression rate is 110. That's where that number came from. We may change it to 2 minutes of CPR. So don't key in on that number specifically. What we're talking about is you're going to begin compressions for 2 minutes. During that time, we place our Lucas, we start our pit crew CPR. So everyone has our pre-assigned role. So when we walk into a code is not the time for John and I to have the discussion of who wants to do what. We've already decided that. That's the premise of pit crew CPR. we place our pads, we start analyzing and defibrillating appropriately, we work down our algorithm. We get a bag mask out, we ventilate our patients twice. We're really looking for, do I have a patent airway or not? If I don't, I go into my foreign body airway. So we're going to assume I have a patent airway. Now I'm down my algorithm and I'm deciding whether I have the primary or secondary arrest. So we're going to go down to primary first. So a lot of us have heard about this passive oxygenation, but we heard about it using a non-rebreather in the past. Well, we have our iGels. So the iGels we're very familiar with. So we're going to place our iGel instead of using our non-rebreather mask. So when we place the iGel, are we doing ventilations? We're not doing ventilations. We're hooking oxygen to our supplemental oxygen port. So you open your port, you hook oxygen to the port. Do we ventilate our patient? No. We're pretty sure positive pressure ventilations during this time actually decreases survival rates. Has to do with the thoracic pressure in the chest, the preload of the heart. So we're not ventilating our patients. Bless you.
Thank you.
So it talks about 3 cycles of 220 compressions. So if you do 3 cycles of 2 minutes of CPR, how many minutes are we talking about? 6 minutes, exactly. So we continue this for 6 minutes, no ventilations, just using passive oxygenation through the supplemental port. After 6 minutes is when we would then start to ventilate asynchronized with our compressions, meaning we do not stop compressions. So how often would I ventilate my patient? Every 10 seconds, exactly, which went back to the front page when we talked about that. Yep. So if we decided it was a secondary arrest, the big difference is we would ventilate right from the get-go 1 breath every 10 seconds. So that's one consideration. The next consideration is what rhythm are they in? So if they're in PEA or asystole, we're going to use our epinephrine from the get-go. But you notice we're maxing our epinephrine at 3 milligrams. So we're pretty sure we don't have great outcomes when we use a lot of epinephrine during a code. We're still going to use it, but we're going to limit it to the 3 milligrams. If the patient presents in VFib or VTAC, we're not going to initially give our epinephrine. So if you think the patient's in VTAC, the heart's irritable, why are we giving a drug to make it more excitable to then give a drug to try to calm the heart down? It doesn't make sense. We're pretty sure that if you do use epinephrine during these cases, that you have worse neurologic outcomes if the patient survives. So we're going to not give the epi, but we would give the amiodarone during the beginning of the code. So we're going to continue this for 6 minutes. So 3 cycles. If after 3 cycles we don't get a pulse return, then we will use the epinephrine to try to get the pulse back. But again, you notice we limit it to 3 milligrams, so 3 cycles. So once you've given your max of amiodarone, your max of epinephrine, we're not giving drugs other than if you have an issue with the H's and T's.
And we've eliminated the bicarb.
So, but that would be part of the H's and T's. So absolutely appropriate, specifically if you believe there's some sort of acidosis, so you start using your capnography elevated. So all those things we've talked about with H's and T's in the past would still absolutely be appropriate to use bicarb. All right, any other questions on this? So again, there are some nuances in here that you'll notice when you sit down and really read it, and we'll go into further depth and actually do hands-on real soon. So if we go back and we talk about we're working the code, and we say, at what point would we consider stopping or terminating the code? So this area talks about when that would be appropriate. So in the past, we would always have to get clearance from the hospital or medical direction. Now we're putting it into the hands of the officer in charge. So if you're working the code and you have a CO2 of less than 10, what's the problem?
Not adequate CPR.
Exactly. your first inclination should be my CPR is not adequate. So either you need to switch someone out deeper, or the position of the Lucas isn't optimal. So you switch the position, you're pretty sure, or you're sure that your compressions are adequate. If you have persistent asystole, meaning more than 15 minutes, and the patient's CO2 is below 10, what are the chances of survival? 0. 0. We now know that. And the key to that is the CO2. We know anytime a patient has a CO2 below 10, 0% survivability. So if you've done all your ACLS interventions, so depending on the rhythm, the drugs have been given, you have an advanced airway in place, which would include an iGel, and you have this situation, we can call it without orders. Again, if there's any doubt in your mind, transport the patient. And probably we would transport, this would be the exception to the rule probably. All right, any questions on that? So when we talk about the pediatric, we already said it's a respiratory problem. So we're going to ventilate immediately, 1 breath every 6 seconds. But it still talks about withholding the epi for those 6 minutes. Now, when they did the study was actually done only on adults. But we reasonably believe that it will correlate to the pediatric, so we're going to try it. But just be aware, that's one of those cases where if we find that, you know what, maybe this isn't the greatest idea, we may go back. So, I've said numerous times that these new protocols, if you enjoy EMS or into EMS, this is an exciting time. If you don't, this is the worst time ever, because we're going to constantly be tweaking and trying things. So these protocols, some of the things we're trying, they're absolutely based on evidence, but as you know, if you've been around a while, things seem to change, and sometimes we're tweaking things. So we're definitely going to start doing that with this. But with the studies that have been done, we already have really good ROSC rates. And more importantly, before we used to just look at getting a pulse back. So now we're pretty good at that. Now we're taking it one step further. We want people to walk out of the hospital and have some sort of quality of life. From what we know from the studies and other departments that are doing it, when we implement this, our ROSC and survival rates are going to go up even higher. So we're going to try it. We're relying on feedback from everyone, and then we'll adjust accordingly. So this talks about the CO2 level again. Talks about H's and T's. If anyone has a specific question, we can talk about it. Otherwise, I'm going to keep going. Some special considerations. We already talked about hyperkalemia. So the treatment we're familiar with. The excited delirium, high probability, they're acidotic. So there's a great example. You absolutely would give your Bicard, cool them down. So you can read those. Does anyone have a specific question? We're good? Okay. The hypoglycemia. So why 250 in this case? There's no real rationale for the 250 a D10 other than we didn't think it would be appropriate to say, okay, give 100, check the sugar, give 100, check the sugar. So we figured if the patient was hypoglycemic after 250, you definitely fix the problem. That was the only rationale. So don't read into that mLs. The CPR-induced consciousness. So I have not seen it, but apparently, particularly with the new Lucas devices, when we're doing CPR, we have patients waking up. And we think that they're waking up because they regained a pulse, but it's actually the CPR that's making them conscious again. As soon as we stop CPR, they lose consciousness and lose pulses again. So if you're faced with that scenario, that's a real scenario, remember that the treatment would be 100 milligrams of ketamine to sedate them a little bit so they wouldn't be discomfort and you could continue doing the compression. Right, that's why we switched on here. You'll notice some of the language and stuff is slightly different on here, and that's why I say even on this, the content, the ideas won't change. Maybe the language will change slightly, but the ideas will still be the same. We just want to make sure it reads is easy. That's why we're relying on feedback to make sure we eliminate all the questions. So when we talk about refractory VFib VTAC, it again talks about shocking, and this is where they talk in the county about the double sequential shocks where you put 2 sets of pads. Right now, we're not doing it, but we may include it in the future. So that's where that spot would go. So we're gonna wait and see how it goes. So we may add it, we may not. So post-resuscitation, really, when you get the heart rate return, give the patient a chance to stabilize. And most of the time, the issue is with blood pressure. So we've already said several times, how do we increase blood pressure? We're gonna give our fluids and our push dose epi. So again, you see, push dose epi repeats, very easy to administer. So we're hoping it takes a lot of the guesswork and anxiety out of any of the protocols. So you notice the ice pack. So why ice packs? Well, we're not trying to do hypothermia anymore. The only thing we know is that hyperthermia is not good. So if the patient has hyperthermia, you would definitely want to use some ice packs to bring them down to at least normal thermia. You could use the ice packs, and if we go to a facility and they start the ice, the cooling procedure, it's a good reminder for the facility to start that. So we're not doing that for the purpose of trying to go to hypothermia. The VFib VTAC, again, talks about if you convert them after 1 shock, you would not give the amiodarone infusion, but if it took 2 and more, you would. Same idea, that we're not going to give amiodarone if it's not needed.
And that's still even if you gave the pushes, right? Or are we still maxing?
No, that's saying you didn't give any.
Okay.
That's saying you hooked the patient up and shocked them right away. Right. So pediatrics, same idea, making sure we're oxygenating adequately, and then we're worrying about our blood pressure. Okay?